Hi, my name is Gerds, and I'm the editor-in-chief of ASH Clinical News. And we are here at the ASH annual meeting for 2023 with our on-site coverage. And it's my absolute pleasure to be here with Dr. Portell, who's going to tell us a little bit about the abstract that he presented. Welcome, Dr. Portell.
Thank you.
First of all, before we get into things, tell our audience a little bit about who you are and where you work and what you do.
Like Dr. Gerds says, I'm Craig Portell from University of Virginia Cancer Center and in Charlottesville, Virginia. I mostly focus in lymphoma and CLL treatment for our patients.
All right, well, thank you. Thanks for being here to discuss your abstract. And by the way, congratulations on a wonderful piece of work.
Thank you.
It's always exciting to finish a project and be able to share it with all your colleagues.
Yes, for sure.
I think just to kind of get our audience up to speed, this study was done through Precog.
Yes.
Which isn't ECOG, but is ECOG, but isn't. And,
yes.
Maybe our readers may not be familiar with what Precog is. Could you explain what that is?
Sure. So Precog is a part of ECOG, but not ECOG itself. So it's not through the NCI-funded mechanism, but it's a way for ECOG members to design clinical studies that then get funded mostly through pharma company collaborations. Yeah. So it's a way, usually kind of more pilot studies, more feeder studies into the ECOG mechanism.
Yeah, and each of the NCI cooperative groups had this mechanism. So SWOG
yes.
has one that's very similar, and so on and so forth. So,
yes, yep.
So it wasn't a proper NCI-funded trial, but still through that network of
yes,
centers.
so the investigators within ECOG would have contributed to some of the insights into the Precog studies.
Oh, great. And so this is a trial looking at adding venetoclax,
yes.
as we do to everything now,
Seems like
venetoclax to bendamustine and rituximab for mantle cell lymphoma.
Yes.
So in your abstract, you kind of start to state the standard of care as it is now, and what are some of the shortcomings of the standard of care for those patients with mantle cell lymphoma?
Well, standard of care is certainly evolving, and there's a lot that is being assessed right now. So we're still highly awaiting the triangle study for mantle cell lymphoma, and that's mostly for patients who are younger. This particular study highlighted patients that were older who could not have gotten a stem cell transplant, which is close to the majority of the patients that have mantle cell lymphoma. Usually we consider bendamustine and rituximab as a good standard option for those patients. And this study was attempting to see if adding an additional agent would help those folks. I think the field is moving a little bit away from chemotherapy now, so we'll have to see how this gets incorporated.
So what is the field moving to?
Mostly chemotherapy-free approaches, so things like BTK inhibitors or venetoclax, monoclonal antibody with CD20. Various different combinations are out there, and how we move forward in that space is not really quite clear.
But still, this is a great option for patients who don't have these other options available.
Correct, yeah. Combining all those drugs together and how long you treat them, we just don't know that yet. So all that chemotherapy-free is not quite to prime time yet. So this is an option to give chemotherapy plus a targeted agent in a limited time frame.
And how big was this study?
33 patients. Yep.
And I noticed partway through some of the analysis were adjusted. The power calculation was adjusted.
Yeah. So there were two reasons for that. The first was, we started this study in January of 2020, and we all know what happened in March of 2020, the COVID pandemic. So our enrollment slowed mostly from opening sites, new sites. And we also got an early readout of the ECOG study 1411, which compared bendamustine and rituximab as one of its standard options. So we got an early readout of the CR rate, which was our primary endpoint. And that CR rate allowed us to modify the study to potentially lower the patient numbers. So that's what we did.
Yeah, I know there's been a lot of press actually around lately about trials changing their endpoints or changing their power calculations midstream, but it sounds like this was very justified and was really, you were adapting to the times.
Adapting to the times and adapting to new information also with that new information about the CR rate.
Yeah, there's been so many trials that have been just kind of absolutely just submarined by new data coming out, and I'm glad to see that you were able to adjust and continue on with getting these results. Yeah. So being that we are transitioning over to results, what is the kind of the one-liner from this? What is the one, if I'm out there practicing, out in Normal, Illinois, what is the one thing that I got to remember in the back of my mind about this trial?
So we had a very high CR rate, 85-ish%. That CR rate was despite having a very high-risk patient population. So we had a quarter of patients had blastoid morphology, and 2/3 were high-risk MIPI. So it was a higher-risk patient population. How those patients fared with the combination compared to others, we're going to find out with subsequent analyses. But we did have a very high CR rate.
Yeah, I was incredibly impressed by that super high CR rate. That was astonishing.
Yes, we'll see what PFS happens. Hopefully that maintains.
And so I know you mentioned a lot of newer therapies coming along that aren't quite prime time yet, but how would a treatment like this kind of be incorporated into the sequencing of treatment for these patients?
So hard to say at this point. I think most of us would still, it's only a 33 patient study, so I don't know that I'd completely change practice based on this, but maybe we'll get some more information from the study, from correlatives and subgroup analyses that may kind of help us determine who bendamustine rituximab may not be the best option for initially, and maybe have some other options for those higher risk patients.
And so the next question is always the forward-looking question. Where do we go from here? Are there additional plans to develop this therapy overall, or is there any pivots from what you've done so far?
So this combination is probably not going to move forward, just generally thinking how the field is moving. Of course, it was designed 4+ years ago, and it's just the way it is sometimes. But we may get some signals about venetoclax treatments and some understanding of chemotherapy toxicities in the COVID era and T-cell mediated toxicities and things as we go forward.
Yeah, and I certainly don't want to downplay the results. I mean, this is it was a momentum, like a large amount of work. Certainly a tour de force to pull all this together and get this study done.
Sure, yeah.
And definitely we see incremental increases in care for these patients, right? So we learn more about venetoclax as an agent within this space, and you can then take that forward to other trials using other innovative agents. And so certainly it's definitely a step forward for the field. And again, thank you for joining me today and sharing the results of your abstract, and thank you for working so hard on this project.
Yeah, thanks for having us and allowing us to talk about the results.
My pleasure. And for all of you out there viewing this video, thanks again for joining us for this discussion. You can read about this abstract and all the other annual meeting coverage in the pages of ASH Clinical News, as well as on our website. So until next time, we'll see you later.